All right, welcome everyone to the Overcoming Chronic Illness podcast. I'm very excited today to be joined by Dr. Lauren Tessier. Dr. Tessier is a naturopathic doctor who practices in the US of A. And Dr. Tessier, if you don't mind just telling us a bit about your background, that would be great.
Yeah, thank you for having me. What a name for a podcast, right? You're gonna
A
be
lofty goal.
having yeah, have a lot to cover for sure. And mold's definitely one of them. So a little about myself, like you mentioned, I'm a naturopathic physician licensed by the state of Vermont here in the United States. I was trained out at Bastyr University, and after graduating, I headed back east. I'm originally a New Englander. Hung my shingle in Vermont, and there I was practicing primary care. That was the goal. And as I was kind of chugging along, started to see quite a few cases that were non-responsive to a lot of, our common things. The most common one was like the brain fog and fatigue, so right off the bat, you start thinking, oh, anemia, vitamin D, macrocytic anemia, what else could be going on? And, the easy stuff was non-responsive. And then once we dug a little deeper, we found out that the person had been maintaining a home office in a basement that had been flooded by a hurricane that came around in 2011. And a lot of people don't think about hurricanes in Vermont, but we have the big mountain ridges, and it all has to go downhill somewhere. And in this case, it went into this particular town, and it was really eye-opening, because they don't cover it much in school. I think any school education, they don't cover it much. Hopefully that's changed by now. But so
Sorry to interrupt, but do you know if it's changed at all with Bastyr? Like, do they talk about mold illness at all?
I don't know. I think probably the closest our environmental medicine physician did do a little bit of lecturing about toxic mold, but it was probably like 5 minutes in a one-day thing,
That's
but of
probably not
course,
enough.
no, probably not enough. I'm still learning and still teaching, even to this day.
Hmm.
There'll always be plenty of information. Yeah.
Hmm.
So with this particular client, that kind of got me going on, okay, I'm going to start asking people about, water damage in their home or work or whatever, and what their exposures look like. And then it just blossomed in front of me. And you're like, oh my gosh, there's so many people out there with this exposure and with these chronic issues. And so that really pushed me into training. And so I started off with chronic inflammatory response syndrome. At the time, it was one of the most common or most widely available or most known of mold illness kind of courses,
Hmm.
certification. So studied that, sat for that license, or not license, that certification,
Hmm.
and then hung my shingle for my mold practice. But then as time marched on, it was like, there's really more than one way to treat someone, and not every single mold reaction, illness, what have you, is SIRS. It's not.
Hmm.
And with how different people are, it's not a one size fits all. It'll never be a one size fits all. It's great to do that when you're starting to learn, and really starting to understand something to its core. But in clinical practice, you need to have that flexibility. So I started digging deeper and started just educating myself even more. And that's more or less how I started to educate other people, and started lecturing and doing all that kind of good stuff. And I became involved in ICI, the International Society for Environmentally Acquired Illness. They're an educational professional nonprofit that teaches physicians, or brings a community of physicians together who do this on a day-to-day basis. And so there, with that organization, I started as a board member and kind of moved up through the ranks from secretary to vice president and now president. And it's been a really humbling experience. It's been such a humbling experience, and it's such a wonderful community to see so many physicians learning from one another in a really warm, kind way, and just kind of bringing new ideas to the table. So that's kind of where I am now. I maintain my mold illness practice I also do educational consulting for people. And then I lecture, and I do plan on staying with ICI for as long as possible. So that's kind of where I am now. That's me in a nutshell.
That's a good nutshell. That's a pretty full nut, I think. Yeah, and ICI is just such an amazing organization. I've never had the opportunity to date to go to one of the in-person conferences, but just from what I gather from the online forum and the recordings of other courses and whatnot, like yeah, there's just so much integrity and compassion and just innovation. It's just awesome. So it's a
Yeah.
great group to be the head of. I would say. Um, and oh shoot, I was going to ask you something else, and it escaped me. Okay, I'm sure it'll come back to me.
It'll come back.
I'm sure it will. Um, I know that at least you're a bit synonymous with mold toxicity in my mind. So maybe I didn't want to pigeonhole you with this interview. I have a bunch of questions on a bunch of different topics. Of course, mold toxicity has its tendrils in so many different areas. But if it's all right with you, I'm just going to start off with a question about mitochondrial function, if that's okay.
Sure,
Um,
absolutely.
so as anyone who follows me on social media knows, I have a bit of an obsession with mitochondrial health and function. And a couple of years ago, I know that you wrote a great article in the NDNR looking at the impact of mycotoxins on fatigue, and you talked about mitochondrial dysfunction in there. And so I'm just wondering if you could tell the listeners what approach you take, kind of a two-part question. So the first part is what approach you take to assess mitochondrial function in patients that you're working with.
Sure. So when I work with clients that, well, I have to reel it back a little bit. So the biggest mechanism of action that we think for mycotoxins is oxidation leading to lipid peroxidation. Lipid peroxidation is, the damage of fatty substances, and fatty substances make up our membranes of all our cells, our membranes of our organelles, including the mitochondria. And so there's a good amount of research that shows that there's a lot of just outrageous mitochondrial dysfunction that happens with mycotoxin exposure. For me, I do more of an approach of kind of the what I need to fix when it comes from a mycotoxin standpoint, rather than how severe. I don't know if that makes sense. So I don't do the AOH DG. I don't do that. I don't do the malonaldehyde. I'm sure a lot of people are gasping right now at that point, but for me, it's more, I want to get their toxic burden down, and I want to do it in a way that's as affordable as possible without kind of adding too much data onto it. And then based on clinical symptoms of what's happening, of how well their detox pathways are moving forward, how well just the rest of their global metabolism seems to be moving forward, then I'll tweak things there. I'm sure that there's more. I'm sure I could learn a lot from you when it comes from that topic. But yeah, I try to KISS, right? I try to keep things as simple as possible when I work with people.
And just for anyone who's not familiar with the KISS acronym, keep it simple, stupid, I believe, or maybe that's
keep it simple, sweetheart.
Is it sweetheart? Oh my gosh. Okay. I'm going
You're
against
right.
all Canadian
You're right.
stereotypes here. That was so unfriendly of me. That's the only I've never heard the sweetheart. That's much nicer. Yeah.
I think that's just the mother in me where you're
Okay. That must be it. There was one lecture I went to once, and the guy actually was like a weekend course, and like the guy just said KISS like on every slide pretty much, and he just always said keep it simple, stupid. I think it's like a Pavlovian response for me now. So anyways, yeah, keeping it simple for sure. And like despite my questionably healthy or unhealthy obsession with mitochondria, my favorite test is just ask the patient, like, are you tired? And if they say yes, you've got mitochondrial dysfunction. That's the end of the story. So in terms of like say organic acid testing, or like some of the genetic tests that are out there, or like genomic testing or something, like do you look at any of those things with patients to assess their mitochondrial function?
I will let those inform a case if they've been done by other physicians.
Sure.
So if someone's like, oh, I have an oat test from a month or two ago, can I bring it in? I'm like, sure, let's sit down, let's look about this. Also like, what supplements were you on when you were taking these? These are a snapshot in time. But that's to say with every test, you know.
Hmm.
So the oat test, you know, I don't use again as often as
Hmm.
maybe other physicians, but I will absolutely look at it. And the genetic component, now this is gonna maybe rock some people's worlds.
Bring it on.
But
Bring it on.
yeah, when it comes to genetic stuff, I actually love looking at SNPs, especially for your phase 1 and phase 2s, because that's really what I'm focusing on kind of like draining the sink, draining the tub, you know, draining the bucket is
Hmm.
working on those detox phases. So I get really excited about what's happening with um, your CYP pathways, what's happening with your GST pathways, all of that kind of good stuff, your
Hmm.
UGT pathways, um, even more so, especially more so than the genetics that come with the whole SIRS picture of
Hmm.
the HLA, DQB, DQR. I just never saw the clinical application in those. I
Hmm.
didn't see it translate into my clients. And it was also like, well, if I can't change anything about these HLA genes, but I can induce or kind of slow down some of these phase 1, phase 2s,
Hmm.
I'm going to get more bang for my buck in having someone order $200-300 test or go to a consult with someone to get that data than if I'm going to order those and then scare someone into thinking that they're the dreaded gene for the rest of their life. So
Hmm.
definitely a nerd when it comes to the detox genetics. But
Hmm.
again, when you step back and you look at it, it's like green tea, caffeine, you know, all of your inducers are, and so it really just comes back to like, okay, well, we're doing a very similar approach for a
Hmm.
lot of these different things. So
Hmm.
yeah, it's I consider it like a little bit of navel gazing or shoe gazing, where like you can examine things and pick things over and over and over and have lots of fun, because I think that you have a data oriented mindset.
Hmm.
I'm guessing similar to myself,
Yeah,
and so
for sure.
it gets really fun to go through and dig down, and then, you know, after you've done this 10 times, 30 times, hundreds of times, you're like, okay, it's a very similar approach for a lot of what we're doing here.
It's so true. Yeah. It's yeah, I oftentimes will say to patients when they're making that decision, like, okay, are we going to do testing or are we going to, move ahead more clinically? And it's like, well, of all the hundreds of reports I've seen, like, these are the most common things that come up in analogous cases. And, sometimes you get surprised, but
Right.
yeah, there's something to be said about clinical experience. It's valuable in many ways.
Absolutely. Absolutely. And then there's always the clinical experience where you move through knowing these things, and then you get, like you said, like you get that curveball, you get that
Hmm.
surprise every now and then. So
For
yeah.
sure. Yeah.
Yeah.
I do have one other mitochondrial question there, but I did remember what my other question was that I forgot earlier. You mentioned when you were giving your little mini bio there that you do educational consultation, I think you
Mhm.
said. And so would you mind just elaborating on what you mean by that?
Sure. So I don't know if this is the same thing in Canada, but in the United States for naturopathic physicians, we have different scopes of practice in different states.
Hmm.
And so in the US, that's our biggest issue when people are going from state to state, even if it's a licensed state. So in the state of Vermont, we have huge prescriptive rights. Maryland, you have licensure, but you need to be supervised under an MD. And so what ends up happening is, I think a lot of people you tend to practice in a cavalier manner
Hmm.
here stateside, but I like being very cautious.
Hmm.
So with the educational consults, what it ends up being is I'm not prescribing, I'm not ordering tests, I'm not providing super bills, I'm not diagnosing. Instead, I'm speaking globally about a case and kind of putting together a write-up for someone to bring with them to their physician to have
Hmm.
these dialogues. And one of the things that we do encourage people to kind of iron out beforehand is making sure that their physician is receptive
Hmm.
to getting this feedback and hearing this education. So that's really what an educational wellness consult is. So I
Okay.
have those clients through Life After Mold, and then I have my Tessier Medical, which is my actual patients who are coming in, having their butt in the seat, and we're doing all of, you know, the prescriptive, the ordering labs, all that kind of good stuff.
Gotcha. Okay,
Yeah.
great. I was wondering if it might be something like that. And
Yeah,
at the end of my litany of questions here, I'm just going to ask you about some of those opportunities for folks to work with you. So maybe we'll circle back around to that at the end, if that's all
sure.
right. Um, but thanks for explaining that. On the mitochondrial level, so you've got a patient and you've deduced that they have some mitochondrial dysfunction going on. So of course you're working on addressing the root cause factors that might be leading to that mitochondrial dysfunction. In terms of actually supporting those wonderful little organelles themselves, though, to help breathe some life back into those mitochondria, what kind of things do you work with to treat the dysfunctional mitochondria?
Sure. And I go very simple on that because I tend to have a lot of people who have, um, my biggest issue with clients is usually a mast cell activation thing that prevents
Mm,
me from putting stuff into them, as I'm
mhm,
sure that you're very familiar with.
mhm,
So a lot of these multi-ingredient products, I can't, they can't touch people. I
mhm,
can't get them into people. And so usually there's like an MCAS thing, or that's mast cell activation, sorry if people aren't familiar, thing that we have to address first before we can do that. And even then I'm doing kind of step-by-step slow integration of some of this mitochondrial support, and things as simple as, how does a high fat diet look? How do fat soluble antioxidants look? Carnitine's always a big one. CoQ10's always a big one. Um,
and
the
sorry to interrupt, but like, are
Yeah,
you doing like lab tests to assess those, or it's more like those are definitely ones that are going to be part of your protocol if you can manage to get it into the patient?
those are ones that are going to be. I hate using the word protocol, but those are going to be the ones that I'm going
Or
to choose.
the prescriptions,
Yeah,
maybe. Is that
yeah.
the word?
Like I
Yep.
no, I think it's not so much the. Yeah, I think it's the protocol. I worry about the cookie cutter
Of course.
concept, right?
Sure. Yeah.
So yeah, those are usually my safer ones to go
Hmm.
to before we start playing with some of the other things. Red light therapy is always seems to be really well tolerated for my clients. And then after that, then I start to get in some of the B's and trace minerals following that. But I really want to set the foundation with what constitutes that mitochondria, and that's usually like fat and how we move fat around the cell. So
Hmm.
that's usually the foundational approach I'm taking from there.
And so in terms of the fat, is that like through mostly through dietary fat or essential fatty acids or phosphatidylcholine, or what's
Yeah,
with that?
so phosphatidylcholine is always a cornerstone for me with folks. And then, I hate saying the keto diet, but because it has its pros and cons, and different constitutions don't work as well with it.
Mm-hmm.
Um, but even just asking someone to integrate more high quality grass-fed saturated fats into their diet is usually what that looks like. So I'm doing it dietarily and with phospholipids first. I find that phospholipids are really well tolerated.
Mm-hmm.
I don't worry too much about the see, now my brain is going to blank, um, the uh, the cardiac dangers with poor phospholipids. I don't see that toxicity all that often.
Mm-hmm.
I think it's the TMNs. It's the pregnancy right now.
For
It's
sure.
pulling that answer out of my brain. So I find that the phospholipids are really generally tolerated, as well as high fat diets. And if that's not um, making that foundational step, that foundational padding, there's usually one step back where it's kind of like, okay, what's happening with the liver? Do we need to be supporting with TUDCA before we move into it? So, it's always this kind of like middle ground of supporting the fat, but then what are all the layers that either come before it before we can get deeper into the mitochondria?
Mm-hmm.
Yeah.
And just on that kind of phospholipid note, because I've taken several runs at using phospholipids in my protocols, and um, it's been relatively rare that when I've prescribed phospholipids to patients that there's been this like really obvious clinical change from that itself. It's not like, oh, I went on my phosphatidylcholine, like my energy's so much better, my brain's so much clearer. And I'm just wondering if either I'm just having bad luck, the water's different here in Canada, or I'm wondering if the phospholipids are more of like just sort of like you get those in place and then you find, oh, when those are in place, then patients tend to respond better to future therapies, or
Yeah.
they tolerate things better.
Yeah, definitely the latter. I don't
Okay.
really see, other than the phosphatidylserine sometimes helping
Hmm.
with people's sleep
Sure. Yeah.
at night in
Hmm.
like the rare 5% of cases.
Hmm.
I don't see big drastic change. I've had a couple of
Okay.
clients say like they inflame it from an inflammatory perspective. They feel cooler, which I
Mm.
think is interesting. I get a
Hmm.
little bit of a huh.
Mm.
But other than that, it lays the foundation to decrease some of the reactivity, especially what I find to be the binder reactivity later on. So yeah,
Okay. That's great.
you're
So,
not
and
doing anything wrong.
good to hear. And so if I was to simplify or like uh, condense what you just said down into like a single bullet point, would it be like it helps to improve tolerability of future treatments, or does it make future treatments more effective? Not that those are mutually exclusive.
I would say a little bit of both, but the toleration
Hmm.
seems to be the stronger point there.
Okay.
Yeah.
And where I'm going to ask you about MCAS and histamine next. So you already segued
Yeah.
into that earlier, which is great. Do you think that, or think or know whether or not phospholipids are helpful with mast cell stabilization at all?
I think of everything as 6 degrees of separation in the body. I don't know if you've ever played that board game, Six
Yeah, yeah,
Degrees of Kevin,
yeah.
but yeah. Anyway,
Hmm.
I'm dating myself on that one, but um, I it's one of those like yes and I'm
Hmm.
sure that we could find some type of connection between phospholipids and between helping to support the membrane stabilization or the something about like the lysosome stabilization so it's not dehisting as much or like I'm sure we could find a connection.
Hmm.
um but I don't consider phospholipids to be part of my MCAS treatment, maybe the foundation to get it to be tolerated. um but I don't consider it a particular modality for
Hmm.
MCAS. And other physicians might be screaming right now, but so that's my approach for it.
Okay. If
Yeah.
anybody's screaming, please email me or contact us and let us know because it'd be nice to know if somebody has found
Yeah,
that. Like,
I'd love
okay,
to see the PubMed ID on that and
for
like the
sure.
study on that. That would be amazing.
Yeah.
Please edify me. I'd love it.
For sure. Yeah, it's never hurt. Yeah, we always want to learn more. Obviously, there's always so much to learn. Well, it's actually kind of a good segue into the next question because one of the things that I lament in practice is that, like, I feel like, for example, in the realm of treating chronic infections, where I mostly use herbs in that regard, there's like so many different herbs you can choose from. Like, oh, patient, you can't tolerate this or that didn't work for you. There's like dozens of maybe not, yeah, probably dozens of herbs that we could pick from an antimicrobial perspective.
Yeah.
You phase into the realm of mast cell activation syndrome or histamine intolerance. It's like, well, let's just say MCAS for this purpose. There's not really that, to my knowledge, anyways. There's not really that litany of like multiple products to choose from. I mean, you've got your certain categories of pharmaceuticals.
Mhm.
You've got, some natural products. Every time one of the many reasons I love the ICI conferences that there's always a focus on MCAS, and I'm always like listening with bated breath, like, is somebody going to talk about a new intervention?
Right.
And like, it's so rare that something new comes out. And so anyways, with that preamble out of the way,
Yeah.
could you share what some of your go-to pharmaceutical and non-pharmaceuticals are for mitigating histamine symptoms?
Yeah, absolutely. So with mast cell approaches, first thing I'll say, surprise, surprise, I don't test. I don't bother testing for mast
Mm.
cell. I get into a dialogue with my clients where we're treating presumptively here, because a presumptive treatment can also kind of be point towards a diagnosis a little bit, and we're using very low risk interventions. So once
Hmm.
people are kind of consented and aware of that, properly
Hmm.
informed,
Hmm.
we usually move forward because the testing, as you know, it's like you need a baseline, and then when someone's in their flare feeling the worst of their worst,
Hmm.
they need to schlep to a hospital that actually is like it's no, I'm
Not
not going to
ideal.
do that. Yeah.
Hmm.
So I do a lot of presumptive treatment, and I start with my H1 then H2 blockers.
Hmm.
You know, and the reason why is I find that herbs can get you in trouble. A lot of people freely use herbs without um, thinking about the risks, they think,
Mm,
oh, they're natural, so they must be great. And you and I both know, like, you can really upset someone's system with herbs. And so
mhm,
I think that there is a time and place for pharmaceuticals and direct targeted pharmaceutical action. In this case, the H1s and H2s. I tend to be a big fan of Benadryl, so the first generation H1s, unless someone tends to have an antithetical reaction where they get stimmy with it.
mhm,
And then I'd consider going to the ones that don't cross the blood-brain barrier as much. H2s, Pepsid AC, a lot of people are really nervous about that one just because they usually come to you and they say, I've worked on my gut for so long, like I
mhm,
don't want to throw it off.
mhm,
And I always try to reassure people that we're not necessarily blocking acid. I'm sure there's a couple of degrees of separation between H2 and blocking acid, but it's not a omeprazole or anything like that. We're
mhm,
working more the histamine target. So H1, H2s, and I like those because they're over the counter. They
mhm,
have low financial risk. They have just so much going on with them. So I try to go as easy peasy as that. After that, we'll go into cromolyn, we'll go into ketotifen. Those are kind of my second levels just because cromolyn's a pain in the butt and ketotifen has to be compounded, which
mhm,
can get expensive. But the nice part about cromolyn too is you can directly target different tissues. So if someone is having more of a mast cell GI issue, you can do the liquid, or if they're tending to have more of a nasal respiratory, you can do, the nasal sprays or even the eye drops. So I think that there's a benefit to cromolyn on that front. And then moving on from there, you know, there can be an amalgamation of all of those H1, H2s, and stabilizers. And then once I kind of get someone balanced, and we maintain them for a while and we do our detox work, then we'll start to consider bringing on a natural substance so we can kind of put something more natural on and take off something more synthetic for
mhm,
people. But usually once we get the mast cells kind of calm down, then once we get the mast cells calm down, then we can move into detox. And then after that is when we start to work more the immunomodulation of trying to get things balanced back in. And then we take off the mast cell stuff.
mhm.
Um, from the herbal perspective, gosh, people love quercetin, and I see like a 20% effectiveness. And like people can get up to like 3,600 milligrams a day. Like
A lot.
right, it's tons and it's so expensive.
Mm,
And it's a mixed bag. And I'm always surprised when someone says, oh yeah, I take quercetin, I do great. Okay,
mhm,
perfect. Like let's not change that.
mhm,
But there's just there's so many different things that people say from an herbal perspective can help mast cells. And I see it and I see some benefit. And heaven forgive me, but I feel like a lot of times it's people who might be a little bit newer to botanical medicine
mm,
who engage it in a way that like it has all the answers,
mm,
because it doesn't. Like quercetin is not always going to work in someone. ECGC is not always going to work for some, or the green tea extract. Black seed is not always going to work for people. So I don't know. I have a little bit of mixed emotions there. And then on top of it, you'll have patients who'll come in who'll say that has the oxalates in it. Like I
mm,
can't do that. And
mhm,
so I feel like there's a little bit more safety in the pharmaceutical approaches. But if someone comes in and they say, I don't want to do the pharma, I'm always going to work with them and try to
sure.
do the more natural approaches. But if we're going from brass tacks where, no one has a desire to move one way or the other, I'm usually going to start with the over-the-counter pharmaceuticals.
Mhm. Great. Yeah, me too. For all the reasons you said. I think my success rate with quercetin's a little bit higher, but I also find that if a patient's like in just full-blown MCAS mode out of the gate, I don't even bring up the quercetin as a rule unless
Right.
pharmaceuticals are off the table because it's just so rare that it helps. But once things start to settle down enough, it sometimes works better as they're settling a bit, as you were alluding to there, I think. I have about 10 more questions that just generated from
Sure.
everything that you just said. So we're never going to get through this list, but that's okay. It's all been riveting for me so far. So one happy camper in the audience anyway so far. So just a couple of maybe more rapid fire questions here.
Yeah,
I'm just wondering, so if you have a patient who's say already on like H1 blockers, so
yeah.
and I know the names of the drugs are a little bit different across our borders, but like say that would be like Zyrtec or Reactin or Arius or different ones that are out there. So you have your H1 blocker. If you have a patient who's already on an H1 blocker and then an H2 blocker is added in on top of that, I'm just wondering what percentage of the time do you find that that H2 blocker brings additional benefit? Is it like 90% of the time, 10% of the time, 50% of the time, like just ballpark? How often is it of additional benefit?
I feel like the H1 is a 40 to 50%, and then bringing on the H2 additionally for people. Um, I'm gonna kind of go from an overall can like bump up the benefit to maybe like those combined to maybe 60% of cases. So it's not a huge one
Hmm.
by
Okay.
any means. Yeah,
Hmm.
usually if we're not finding the benefit in H1,
Hmm.
I I have a little bit of foreshadowing in my gut that we're probably going to need an H2 and cromolyn
Hmm.
to move forward.
Right. Okay. And how often, like when patients do go on those H2 blockers, do you find that they have digestive consequences? Really
Very
rare. Yeah,
rarely,
good.
very rarely.
That's great.
It's a hard thing to convince people though, because I mean, gut health
Yeah.
is so in their face all the time. And it's when someone's committed and dedicated, they have given up so much to work
Hmm.
on their gut health. Yeah,
Yeah, I hear you. Um,
yeah.
and then in terms of the dosing for H1 blockers, and I should have said this at the start of our chat, but nothing that we're talking about today should be construed as medical advice. This is all for informational purposes only. Talk to your personal healthcare provider before making any medical decisions for yourself. Um, and I'm not going to ask about specifics of dosing. I might email you later about this, but I'm just curious. Like typically the dosing that you find for folks, how often would you need to go like markedly above what's on, the box, like for the OTC stuff, like
I
getting
have
into
always
more?
I have people start with half tabs
Sure.
because yeah,
Yeah.
I don't know
Always
what's
want to
gonna
start
happen
low.
in
Yep. Yep.
like even
Smart.
lower than the box. Um I I tell people that if you're getting up to 50 and you're not seeing a shift and a change,
Mm.
whether it's with reactivity or the anxiety that comes with the stimulating histamine,
Hmm.
like it's probably not our intervention.
Hmm.
Like I don't want people up on 75 milligrams of Benadryl.
Hmm.
So I try to go maybe 2 times what that suggested limit is.
Hmm.
Maybe more people are, more cavalier when it comes to that kind of stuff, but
Hmm.
um, I still want to push it.
Hmm. And like how often would folks need to go like kind of above that typical like OTC dose like that's on the box in your experience?
Yeah, I feel like quite a few, I don't want to say like 50 to 60%
Okay.
go up to the 50
Yeah.
milligrams.
And like they'll notice that there's additional benefit if they go higher.
Um, no, not necessarily. We kind of get them up to the 50 and
Hmm.
then we stop there. And if they don't have benefit, then we bring on the H2 and add it on as another layer.
Yeah. Okay.
Yeah.
And then also just in terms of like, just for folks listening, so like first generation antihistamines like Benadryl, they cross the blood-brain barrier. Generation ones don't, which is why they're generally marketed as being non-drowsy, although more accurately should be called less drowsy because some people do get
Right.
drowsy from them. And so I know you said, I believe you said earlier that you generally prefer the H1 block or the first generation ones that cross the blood-brain barrier.
Yeah.
Uh, and so I'm just wondering, how, I guess kind of two questions there. So one is, do you how do you conceptualize like why that's more helpful for folks than like a second generation one?
Yeah. So a lot of my clients are coming in with severe neurocognitive symptoms.
Hmm.
And with that, a lot of anxiety or overstimulation or
Hmm.
so I like to see if we can get some reduction in anxiety or whatever that stimulatory picture is as they move through their day.
Hmm.
um So that's why I like the H1. So even this is actually a good segue. Even if we don't use Benadryl, sometimes we'll use the hydroxyzine,
Hmm.
which is a little bit more heavy duty, and it also requires a prescription. So there's a little bit more complication and finances in that. But I find that anxiety can be a huge component of mold illness. And,
Hmm.
is it the histamine? Is it the fact that they're not sleeping? Is it the social stress on the relationship? So anything that I can kind of do to get a little bit of help on that front and a little bit of an improvement in sleep, I'm
Hmm.
going to go after. And so I try to hedge that off at the pass by having people typically dose at night with
Hmm.
it.
Right.
Yeah.
Yep. Okay. And then one last question here, kind of on this topic. So you mentioned, and paraphrasing a bit, but said something to the effect of, we'll bring in the pharmaceuticals, settle things down, maybe phase them onto some non-pharmaceutical options, as things are more settled, and then I believe you said that then you'd start working more on immunomodulation. And I'm just
Yeah.
wondering what kind of immunomodulators or what kind of approach you use to immunomodulate.
All of it. All of it.
Lovely.
I've been playing around recently with the Cyrex lymphocyte map test.
Hmm.
I don't know if you can get it in Canada. It might be only
Not sure.
stateside. But the beautiful part about it is it goes through all of your different subsets. So it goes through your T cell subsets, your B cells, your different NK cells. They put them in ratios to one another. They put them in percentages to one another. So it's like a CBC on steroids. Like it tells you so much data.
Hmm.
And it also lets you know if someone's leaning a little bit more TH1 or TH2 or TH17. I'm going to put a pin in that because the data there is a little screwy too, because we're finding out more and more that my viral response might be more TH1, where your viral response might be more TH2.
Hmm.
So those typical patterns that we've come to know and love might actually be built on shaky ground, which elucidates some clinical confusion for
Hmm.
sure. Like,
It's
oh,
almost
okay.
like the body's complicated or something.
I know,
It's
go
so crazy. Yeah.
surprise. So based off of that, I've been wanting to that has been helpful to clear up some things. So if I see that, someone's maybe leaning a little bit more TH17 and their NK cells are spiked, and they're also someone with a mast cell picture, I'm going to start scratching my head about what's happening with a chronic underlying infection in the body.
Mhm.
And so I'm excited about this test. I'm still learning the ropes of it and kind of going through that process with it. But I feel like it can hold a lot of utility. And then based off of that, then you can start to play with what can I do to support these levels. Or not even necessarily what can I do to drive up a level or drive down a level, what can I do to address the root cause of the
Mhm.
dysfunction of this level.
Mhm.
And so immune modulators, I mean, one of my all-time favorites is melatonin.
Mm.
And melatonin has gotten a really bad rap over the
Has it
past. Yeah, well,
really?
because yeah, um, it's because over-the-counter medications, over-the-counter supplements have been tested, and like 3 milligram melatonin will have 30 milligram melatonin in it.
Oh, wow.
Yeah, and so a lot of these news companies have been running with headlines of "You'll overdose on melatonin." Well,
Mhm.
research shows that you can take up to 300 milligrams orally without negative impact. Um, and they're just using the word overdose as in literal to over the dose that's on the bottle.
Uh-huh.
They yeah, so they don't cite any negative reactions, anything like that.
Mhm.
So a lot of people just read that headline, they go, "Oh, melatonin overdose."
Okay. Mhm.
So it's throwing the baby out with the bathwater. I mean,
Mm.
melatonin is great on so many levels. Um, and so I tend to use that a good amount for immune system regulation of your Tregs, which are I know you know this, but your Tregs are your T helper cells of your white cells that help keep all the other T cells in balance. So it keeps your T helper ones, T helper twos, T helper 17. So they're kind of like the mediators of the immune system. So I mean, melatonin is great for that. Artemisinin is another one that's really wonderful for some of this immune system dysfunction. And then you start to look a little closer and you go, oh, a lot of the things that help with mast cell activation syndrome are also a lot of the wonderful things that support immune system dysregulation. So I find that really trying to find the underlying cause of the dysregulation that's leading to the MCAS,
Mhm.
and then addressing it rather than just forcing cells to go up or down, is usually my approach.
Mhm. Um, that's great. And I mean, with the melatonin, and I'm a huge fan of melatonin, not the least of, one of the many reasons being it's crucial for mitochondrial function as well.
Yeah.
And I don't know if you heard through the grapevine or not, but like melatonin has like been present like since we were all just like primordial goo. It's like
Oh,
been like
wow.
unchanged for like trillions of years in evolution. I think like every living organism, if I remember, has melatonin in it.
Wow.
It just, yeah, it's fascinating. So, anyways, um, with melatonin, aside from folks, regularly having better sleep when they go on it, I'm just wondering if, aside from seeing lab results normalizing or whatnot, are there particular clinical benefits that you see when someone starts on melatonin besides maybe sleep improvement if they're having sleep issues?
Yeah, so there's a few different things there. I don't find that usually above 10 milligrams sleep changes. I tell people when and I put people on higher doses, maybe not as high as some of our peers. Um, but people hear the dose that I would like them to get to, and they
Hmm.
go, but I don't have an issue sleeping. I go,
Hmm.
well, that's not what we're going after.
Hmm.
The absolute systemic antioxidant potential of melatonin
Hmm.
is one of the things we go after. The sleep, sure, as a secondary, but the way I picture it is as a huge nervous system antioxidant, and really helps to bring the aspects of the nervous system into alignment. We see big enhancements in sports performance. And what is that? That is brain, hand, foot, eye coordination.
Hmm.
And with a lot of these mold folks, you have this decrease in the dialogue between those systems. And so using it as a nervous system antioxidant is probably my biggest rationale.
Hmm.
And then one of the other things that I really love kind of wrapping my head around, and this is a correlation, it's not a causation, right? We don't know what's the chicken and what's the egg in this one, but when people are melatonin deficient, they engage in a reflex that I forgot the name of it, that initiates a clenching of the jaw,
Hmm.
which increases your interthecal pressure in your cranium, which kind of puts the brain under increased strain and all the fluid there to try to push things down and out. That's the whole idea. So you'll see that's supposedly that's why, oh, people who have parasites, they grind their jaw. I'm like,
Hmm.
let's reel this back a little and say that
Uh,
maybe people who have a increased need for antioxidant potential might be putting their brain under higher pressure in a way to try to move the lymphatics. And so I it to people where I'm using melatonin as a way to mop up oxidation in the brain. But, if we're going to use that metaphor of that jaw clenching, I'm essentially using it to wring out the sponge that is the brain and the nervous system to try to get that draining a bit more. Um, and the amazing part about melatonin is when I get people up to, not outrageous doses, but higher doses, we start to see a postnasal drip in the morning.
hmm.
And it's really, it makes me really excited to hear, because when I first had people starting to report about this postnasal drip, it was right around the time that they had discovered or reported the lymphatics and the draining
Hmm.
into the lymph chain in the roof of the mouth, then going posterior down the throat. So for me, that clinical connection really made sense. So that's really what I'm using it for, is to just try to open up the flow in
Hmm.
the cranial vault. That's really, and then everything else is a great secondary benefit, and who knows, me using that way might not even be the primary benefit. I might be completely blind to something else it might be doing in the body, and I'm just, getting lucky on that
Hmm.
front, just like anything in medicine.
Yeah. What they'll know in 50 years from now, will be looking like primitive humans
Right.
to them. But yeah, yeah, it's working. That's the most important thing, helping people to get better. But
Right.
that's great. Yeah. Yeah, it's such a fascinating compound, melatonin. Um, I should probably ask you a couple of questions about mold, because
Sure.
otherwise there's gonna be an uproar. It's like, what? How can this, how can you not talk to Dr. Tessier about mold? So just ask you a couple of questions. I know we're getting a little bit short on time. So I'm wondering, what percentage of, excuse me, what percentage of the time do you find it to be imperative to treat the sinuses in patients with mold illness?
Ooh, that's a good question. And it's also dependent on what you're going after and whose clinical logic you're following.
Well,
Uh,
let's use your clinical logic.
my clinical logic. I would say sinuses like 30% of the time.
Hmm, okay.
Sinuses don't come on every single time. And when they come on, or they don't get addressed every single time. And when they do get addressed, they get addressed in different means. Meaning that, do we just need to rinse your sinuses daily at the end of the day to pull off the allergenic mold fragments that are annoying the sinuses? Are we trying to clear out a histaminergic response? Um, are we addressing the sinuses with an antifungal because we're worried about a fungal colonization being um, a possible root cause of the problems? Or are we dealing with the whole bacterial component, the Marcon's picture? um, and I would say out of those three, the first two would be my highest, my two most important pressing reasons to treat the sinuses.
Hmm.
I don't do a lot of Marcon stuff
Hmm.
anymore. There have been years where I've chased it and chased it and chased it without any benefit. Um, and there have been years where I've chased it with the first one without any clinical benefit, the second one without any um, ability to clear it. And then there are other times where we've cleared it and people seem to get re-inoculated, but the symptoms don't come back. And so it really varies widely when it comes to that Marcon's picture. And, I'm not gonna put people in a holding pattern based on a protocol where you have to clear Marcons before you get to the next step. If
Hmm.
that's the case, I would have patients who are still on that step,
Hmm.
5, 6, 7 years later. So my most important things are sinuses are either flushing, just get the mold fragments out,
Hmm.
or doing an antifungal if needed.
Hmm.
If we're worried about something kicking around there. And the antifungal thing, I'm not poo-pooing that. I've had clients where they've had severe um, left-sided neck shoulder pain going from jaw down to shoulder. And we did a nasal ketoconazole. And I mean, this pain had been around for like 10, 15 years, but it was nothing that really ever really manifested
Hmm.
too much in the sinus and the face. And after like 2 days of a nasal antifungal, that cleared up. And you're like, okay, this is
Pretty amazing.
really interesting. Yeah. So, and I always try to be careful with antifungals. Um, there is a higher risk of resistance with antifungals just because of the minimal amount of drugs that we have. So,
Hmm.
there's a lot of risk reduction that has to happen when people are using antifungals for
Hmm.
sure.
Okay. And just to check in, we have about 10 minutes left.
Yeah, we
Is
can we
is
can
that
go
about it?
for a bit longer for sure.
Yeah. Okay,
Yeah.
great. I just want to time manage here. Got a couple more things I definitely
Yeah,
want to
yeah,
cover
yeah.
with you. So another question on the mold front. So just in terms of binders, so to my understanding, primarily from uh, Neil Nathan's book Toxic and lectures he's given and whatnot, and others as well. But my understanding is that there are some, I believe, in vitro studies. Please correct me if there are studies beyond that that you're aware of, that have basically demonstrated that or given evidence to believe that specific binders can be better at binding certain mycotoxins than others. And so I'm just wondering, in your clinical experience, have you found that, say, patients come in and maybe they tested as having like elevated gliotoxin, they were on activated charcoal, but they switched over to something like bentonite clay, which to my understanding is supposed to be a better binder for gliotoxin, and like it made a significant difference. So have you found like matching the binder to the mycotoxin has been clinically important? If you can kind of speak to that topic a bit, please.
Yeah, I would love to. So that for me goes back to um, the idea of doing your oat test and seeing what specific subset thing is out of whack and matching it to this and matching it to that. And you can navel gaze and circle the drain for as long as you want on these things. Like you can make and forgive me for this loose language, you can make a protocol as sexy as you want, where you're like, I'm crossing the T's and dotting the I's. And
Mm,
I was doing that for a while. I absolutely was. Where, I'd cycle people through no longer well call. That's my huge PSA. But I'd cycle through people through, colesevelam, which at the time was like 900 a month before it was on generic.
wow.
And then, I'd say, okay, we're getting a little bit of traction there. This one's still spiked. Like, let's hop over to charcoal and then let's hop over to clay. And then I saw huge variances in the way people were tolerating different binders. And so clay got scratched off my list. And I'll come back to that in a second. But clay got scratched off my list because I was just worried about heavy metal issues
Mm,
for
mhm,
people. And so things started narrowing down. I was never a huge person on chlorophyll. I was never a huge person on fulvic and humic acids. IgG has a potential pin in it. It can be helpful,
mm,
but depending on people's immune system reactivity, it might not be. Modified citrus pectin, sure, that's great, but it's really expensive.
mhm,
Um, and so after all this time, I've kind of just narrowed down to charcoal and well call. And so a lot of people might be, grasping at their pearls, clutching their pearls over that. But, in these studies, if we, what they're doing here is there might be a couple of studies that compare the efficacy of charcoal to clay. But what they're doing is they're typically dumping this into a ton of food that they know have X amount of gliotoxins,
mm,
and they have the control substance eat the food untreated, and then they have the other pigs, cows, what have you, eat the food that has the good amount of clay in it, and they see what the differences are, maybe in the pathologies that pop up, or maybe in the serum levels that pop up for the mycotoxins. And what I just kind of hit a point where if it's been studied, then the connection is being made. But there are some instances where clay was the only one that was studied for this mycotoxin, and charcoal was never studied for that mycotoxin. And so what was happening was clay equals aflatoxin only kind of thing.
mhm,
And so it was this connection in my eyes, and I might have not dived deep enough. But what I was seeing happening was the lack of study proven correlation was a lack of evidence.
mhm,
And I didn't see that happening. I very rarely now have to take people off of charcoal and move them on to something else when it comes to a binder. Unless they're having a poor toleration issue that's either constipation or diarrhea or liver quadrant pain.
mhm,
Um, but yeah, charcoal usually does it all for people, for me. And if they're, and that's really based off its mechanism of action. Like it does the damn thing. Like it has increased surface area. It's a binder.
mhm. It
We
is.
use it, for amanita poisoning in the ER. We use it for Tylenol poisoning. Like it's gonna get the thing out.
Mhm,
And so for me, I stand by its mechanism of action. I stand by its price point, and I stand by its pretty decent toleration. And again, like you can match people to all these different things, but I've seen, I won't name companies, but there are a lot of these like sexy products that have every binder in it, and and it's
Hmm.
a great idea, but people will come to me and be like, I tried that binder and I can't do it. And I'm like, well, I have great news. Let's do charcoal for a while.
Hmm.
And people might be asking, well, then if I'm doing this and I've been on charcoal for 6 months, but my trichothecenes aren't dropping, or my gliotoxins aren't dropping as fast as the rest of them, it's not necessarily because the binder doesn't work. You have different pathways that detox different mycotoxins.
Hmm.
So you might have an uncovering of some of these first. You might have more of this in storage in your cells. You might have a biofilm that's secreting this toxin. You might be chronically exposed. Like, and so I just try to take it from every perspective, while also trying to mitigate the financial harm on people. I see charcoal do a great job, long story short, but I wanted people to understand where I'm coming from when I say that.
That's a great explanation, and I'm a charcoal doc as well, so you're preaching to
Yes.
the converted. And yeah, I've had like some patients where the modified citrus pectin or bentonite clay, like, oh, that's definitely worked better, and that's awesome. But yeah, charcoal just seems to be a good old, old reliable. So
I
that's, yeah,
know.
great to hear.
Imagine how boring we are, Brian. Oh my
I
gosh.
know, I know. Just come in, talk about charcoal. That's about it. Um, uh, I want to sneak in just one other little question here before I ask you
Yeah.
about sort of just ways that folks can interact with you moving forward. Um, but I'm just not sure which if this question applies or not. Do you do much in the way of heavy metal testing?
Hmm. There was an issue that popped up a couple of years ago in Portland, Oregon, or
Mm-hmm.
just maybe just Oregon itself, where provocative testing for heavy metals was getting physicians in trouble.
Oh.
And so a lot of physicians might still provoke. That's great if they do.
Mm-hmm.
I tend to not.
Mm-hmm.
When I do it, I'm doing usually like a um, proprietary lab, some type of like, out of pocket lab for my testing, paired with insurance testing for what I can get for urine and blood. And then I'm comparing it to the NHANES data
Mm-hmm.
and going on from there. Um, with heavy metal treatments, I'll do some of the basic stuff. But if someone needs an IV in the arm, chelation, and they need that approach, I typically direct them elsewhere.
Mm-hmm.
Just because I want them to have a good time. I want them to have a successful outcome. I would say I'm heavy metal literate. I would say, because you can get away with a lot of oral support for
Mm-hmm.
quite a few of these heavy metals. I mean, you can even get away with rectal suppositories for chelation for some of
Mm-hmm.
these. But
Yeah.
yeah, I would say for some of the bigger issues, I refer out
Mm-hmm.
when it comes to big heavy metal issues.
Okay.
Yeah,
And well, maybe I'll still ask the question here,
sure.
because I have some patients, and it's been pretty rare actually. I find somewhat ironically, like intravenous chelation, which we do a ton of it here. It's oftentimes really well tolerated. I've had patients that are like sensitive to every like oral supplement under the sun, yet IVs go just fine. I have theories as to why, but
Yeah.
anyways, yet I've had a handful of patients. One that I just saw last week actually, and like just who just cannot tolerate any form of chelator, like IV, oral. I don't think we've tried suppositories, but I have used them in the past with other patients. And
Yeah.
I'm just wondering if there are. And so like the issue for me is just trying to find, well, what's a non-chelator option to get those metal levels down. And I'm just wondering if there are chelators like non-DMSA, EDTA, DMPS chelators that you've seen historically to bring metal levels down in a meaningful way in your experience?
Yeah, I think a lot of that has to do with the type of metal for sure, right?
Sure.
Because we do have sorry to clear my throat. We do have competitive ion exchange with some of these things,
Mm,
like where they'll compete for our iron, they'll compete
sure.
for our zinc.
Hmm.
So sometimes supplementing those can help modify and move things. I mean, and going back to herbs like cilantro and parsley,
Hmm.
I've seen them do good things, but I've also seen horror stories where someone has mercury fillings and they're given a cilantro product and they just like plummet.
Mm,
um, so, from that perspective, I think that there are definitely things that you can do to whittle away at it. And then when it comes to, again, what type of heavy metal are we dealing with? Are we
mhm,
dealing with an organic arsenic where, if they're avoiding the processed wood products and chicken and, public water, like will this work out of their body
sure.
in time, or are we doing something like mercury that's really going to need to have some type of chelator? So
Mm,
um yeah, I would say that for those sensitive folks, I also wonder what's happening with disturbance of the heavy metals in the biofilm that could be flaring a histamine dump from, one of those little microbes getting out, or an infection flare or something like that.
mhm,
Again, 6 degrees of separation, like what else could be happening in the body that could be triggering? But there's so many great heavy metal training, IV training things out there. I know Paul Anderson does a wonderful one. I know Brendan
mhm.
Cochran. I mean, and you're active in this community too. You're teaching ozone therapies and
That is
things like
true.
that. So
Hmm.
yeah, I'd rank you up there with all of that. So um yeah, I like I said, I would say I float around in the shallow end of the pool. I'm not quite diving
Hmm.
into the deep end.
Sure.
And I wish I had more of a clear answer for you, but
That's fine.
yeah,
Okay. Well, thanks for the feedback anyways. Thanks.
yeah,
Dr. Tessier, I really appreciate your time. Before we part ways here, I just have a couple of questions for you. So if someone's listening to this interview and they're thinking, Dr. Tessier is brilliant, I have to work with her, but I'm not within reasonable driving distance. So you mentioned about doing the educational consults. And so what would the process be by which someone could access that service?
sure. So we usually just have people head on to the website, which is
Mhm.
lifeaftermold.com. And you can just fill out the contact us form there. And if you're like, hey, we want to get started, we will help you best kind of fit into what's going to best be of service for you. You don't have to fly blindly into it. But yeah, usually anyone who's going to the Life After Mold website and looking for care, depending on what they want, need, where they're located, will
Mhm.
either route them into Tessier Medical where they're seen in office, or we'll get them set up with Life After Mold for the educational consults.
Okay, great.
Yeah.
And I'll include that link in the show notes so folks can access that easily. And then beyond that service to folks, do you have any online offerings or other resources for the public?
Yeah, absolutely. So, on my website, I do also have a ebooklet called Mold Prevention 101. It walks you through your home and kind of all the hot spots that could be there. So it can either act as your quarterly checklist to walk through your home and make sure things are, in good standing order. Or if you're feeling really crummy, it could be your checklist to move through your home and see if there's any hot spots. So that 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 freebie, I would say, has served quite a few people worldwide, which I'm pretty proud about.
Mhm.
And that's for free for signing up with the newsletter. And I tell people I don't inundate, I don't, sell spam or anything like that. I'm usually sending out maybe at most like 10 newsletters a year. So
Mhm.
that's in exchange for hopping on the mail list. And then people are always welcome to find me on social media as you are on there. That's actually how we connected first,
Mhm.
through Instagram.
Indeed.
Um, and then of course I've dragged myself onto TikTok, YouTube, Facebook, all the other platforms, but people can find me across most social media platforms as Life After Mold.
Okay, so that's your handle on all of those platforms. Okay,
Yeah.
great. I'll put that in the show notes as well. Yeah, no, I see you popping up on my Instagram feed regularly, and yeah, you seem to get interviewed pretty often. And thanks so much for taking the time to talk to me today, Dr. Tessier. It was great. We got through like this many of the questions that I had for you. I knew we wouldn't get through them all, but even more came up as we went along. But thanks so much for speaking with me, for sharing with my audience, and thanks so much for all the work that you do, with ICI and elsewhere. It's much appreciated. So thanks so much.
Thank you so much. I've had a great time. It's wonderful interacting with a kind kindred spirit. So thank you.
It's kind of you to say. Thanks. Well, take care.
Take care.